Good afternoon or good morning, and welcome to our first 2025 ISBM webinar. I am Mathilde Palmier, and I'm co-chairing this session with Annika Schimanti. I will first give yes?
No, just hello.
Hello. I will first give a short introduction, then Dr. Eva Maria Wölfel will give her presentation. It will be followed by the usual Q&A session and the announcement of the next speaker. So first, ISBM stands for International Society of Bone Morphometry. We are interested in all aspects of quantitative assessment of bone across scales. And this webinar is part of the webinar series, which is organized by the Early Career Investigator Committee. Annika and I are part of this committee, and you can see the other members on this slide. For the 2024 to 2026 membership cycle, the ISBM will host 4 working groups. You can see them on this slide. The first working group will be about HRPQCT, advancing protocols for clinical research. The second one will be about spatial transcriptomics in skeletal tissues, prospects and pitfalls. The third one will be about imaging and analysis of nerve in bone. And the fourth one will be about bone micro and ultrastructure assessment, preclinical models. If you are interested in one of these working groups, then it's still time to sign up because the deadline is on the 14th of February. And if you want more details about the working groups or how to sign up, Annika is currently putting the links in the chat. This working group will run until our next ISBM meeting, which will take place in London in 2026. And in the meantime, please register to the ISBM newsletter to ensure that you keep updated. And also, if you have speaker or suggestions for speaker or session topics, then please email us using the email address that Annika is also putting in the chat. And finally, we would like to thank our 2025 corporate partner, AstraZeneca, for their support for the ISBM webinar series. So I'm done for the ISBM presentation, and now I'm going to present our speaker. Dr. Eva Maria Wölfel has a background in biomedical engineering and did her PhD at the Department of Osteology and Biomechanics in Hamburg, Germany. She used material science-based approaches in combination with biological, biomechanical, and high-resolution imaging techniques to perform an in-depth characterization of bone matrix quality in primary and secondary osteoporosis, with focus on cortical bone from individuals with diabetes mellitus. She is now a postdoctoral researcher in the Molecular Endocrinology Department, also known as KMEB, which is shared between the University Hospital and the Southern Denmark University in Odense. She studies the pathophysiology of bone fragility in patients with diabetes mellitus, and she will present today from molecule to strength, bone matrix properties in individuals with type 2 diabetes.
Thanks a lot for the nice introduction. I would also like to thank the organizers for the invitation to present at this ISBM webinar series. I'm very honored and also excited to present today a topic that is not just a research interest of mine that I spend a lot of time with, but really a companion in my scientific life so far. When we go back using the World Wide Web, looking where diabetes and bone was first described in publications, we can find a publication from 1927 where a radiographic study is presented of children with long-standing diabetes. And in this study, they report a reduced bone mass. But it was not until 1948 and 1952 that the co-occurrence of type 2 of diabetes and osteoporosis was presented. A lot of time has passed, but more recently, diabetic bone fragility is a major interest in the bone research community. And this has led to a meta-analysis and systematic review of Morieri and co-workers, where they showed that there's an overall increased all fracture risk in type 2 diabetes, and especially an increased hip fracture risk. But time passes very fast. And a more recent study has looked at the development of the fragility fracture incidence in a patient registry analysis of a Danish cohort. And in this study, they have found that the incidence of hip fractures in type 2 diabetes, but also type 1 diabetes in the last 20 years was actually declining. This could be due to more awareness of fragility fractures in diabetes patients, and also to a better glycemic control of individuals with diabetes. Nevertheless, the authors conclude that the fracture risk, despite this observed decline in the last 20 years, remains high in individuals with type 2 diabetes. More research has been put to identify what are risk factors that contribute to this increased fragility fracture due to type 2 diabetes. And in this study from a Swedish cohort, they identified a low BMI, a long diabetes duration, insulin treatment, and absence of physical activity as risk factors, which increased the absolute 5-year fracture risk. In another study that came out in the same year, they defined somewhat similar factors, but included also more than one chronic type 2 diabetes complication and a persistent poor glycemic control. So this points towards that there's a specific risk profile that contributes to the increased fracture risk in diabetes. So what are actually the underlying mechanisms that lead to this increased fracture risk? We know that these patients often present with normal or high bone mineral density, so it points towards an impaired bone quality. There are different working hypotheses when it is about the type 2 diabetes bone fragility. And here I'm just displaying a few of the mechanisms that contribute to increased fracture risk and that I will cover in this talk. But let us start with looking a little bit more into the bone tissue. Bone is a hierarchically structured material, and we know that structures at the different length scales, they contribute to the overall bone strength. And in the end of the day, this is what we're interested in. Does the bone withstand the sudden forces or mechanical loading that we are imposing on it, or does it lead to a fracture? So it is important to look at these individual features and get a bigger picture of what is actually going on at the tissue level. In my very first study, we analyzed bone tissue from the mid-diaphysis in a postmortem study of individuals with type 2 diabetes. And we extracted these femoral mid-diaphysis and just did a plain 2D X-ray of radiography of these cross-sections. And we saw that there's a really high cortical porosity in some of the individuals with type 2 diabetes. We wanted to go a little bit deeper into this and extracted the anterior quadrant to look at high-resolution micro-CT imaging. And you can really appreciate this high cortical porosity. When we quantified this, we could see that there's a clear cutoff above 20% cortical porosity. And these cases we only saw in the type 2 diabetes group. So some of these individuals really show with an exceptionally high cortical porosity. This was also been shown in vivo settings using HRPQ-CT by Burkhardt et al. They studied postmenopausal women, and within the type 2 diabetes group, they had 2 cases with an exceptionally high cortical porosity, and these individuals also showed with prevalent fractures. In a similar study, also focusing on postmenopausal women, they found higher cortical porosity, again in the type 2 diabetes individuals with fragility fractures. But how are the microarchitectural differences in type 2 diabetes? In this meta-analysis by Valle and colleagues, they looked at type 2 diabetes, but also type 1 diabetes individuals studies that have been presented regarding microstructural assessment with HRPQ-CT. And here I'm focusing on type 2 diabetes. And what they found was that mostly trabecular microstructure is actually preserved in the radius and tibia, but that there was an increase in cortical porosity in the radius. So this is also what they concluded, that there's an impairment in cortical porosity, while there's an enhanced cortical thickness and trabecular bone structure. So overall, we can see that the cortical bone microstructure is impaired in individuals with type 2 diabetes. When we talk about bone strength in a clinical setting, bone mass or bone mineral density measured with DEXA, but also the microstructure measured with HRPQCT are actually surrogate markers for bone strength. One tool that is supposed to measure bone strength in vivo is impact indentation. It works, basically you have something that is a little bit larger than a pen and with a tip, and you penetrate through the skin. And once you are touching the bone tissue, you enforce a force on the bone tissue, and you measure how deep the probe can penetrate into the bone. And by recording that, you calculate the bone material strength index. We have done this in a post-mortem study prior to extracting the bone tissue. Following the bone material strength assessment, we extracted the mid-diaphysis of the tibia, so exactly the region where we did the bone material strength index measurement, and then performed HRPQCT and micro-CT imaging of these samples. Using micro-CT at 10 micrometer resolution, we again identified a subgroup of cortical porosity, of high cortical porosity. So we discriminated type 2 diabetes and type 2 diabetes with high cortical porosity. And we saw that the bone material strength index and the cortical volumetric bone mineral density did actually not differ in between these three groups using this clinical tools in an ex vivo setting. Only after identifying this high cortical porosity subgroup with micro-CT, we could also see a higher cortical porosity in this group using HRPQ-CT. Others have also applied bone material strength index in a clinical setting, and in this study they showed that BMSI was lower in the type 2 diabetes group and that it negatively correlated with the duration of type 2 diabetes. However, data on this is very varying. So in another study, for example, they showed that there was actually no difference compared to pre-diabetes or normal glycemia groups, while they found a difference regarding ethnicity. In general, the bone material strength index measurement has not been thoroughly validated with regards to its potential to actually predict fractures. A very recent study has tried to do this in a cohort of individuals where they were looking at incident and prevalent fragility fractures. It was a bit of a controversial finding because these authors actually found that a higher BMSI is associated with incident fragility fractures, such as major osteoporotic fractures, but also any fractures, where they did not see any association with prevalent fractures. I think that really highlights the importance of further validating the potential of bone material strength index assessment in general, but also in type 2 diabetes individuals. But let us dive a little bit more deeper into the bone tissue itself and see what mechanisms we can find there. One possibility to do that is applying spectroscopy techniques. Here's an example of Raman spectroscopy, where you use a laser light, and this is exciting the molecules within the bone tissue. And these molecules vibrate and release a lower energy level, which can then be detected by a detector and transformed into this Raman shift. After post-processing all the data, you obtain such a spectrum that is characteristic for bone tissue, and you can appreciate the high phosphate peak, but also carbonate and the amide-1 peak. You can then calculate the area under these peaks, also do some peak fitting and create different ratios that have been described in literature and related to bone quality. In our study of tibia bone samples, we actually found that the carbonate to amide-1 ratio was significantly higher in the endocortical region of the bone tissue in our high porosity group. We did not see any differences in the carbonate to phosphate ratio or in mineralization degree in general in this group. So we were concluding that it is most likely that the amide-1 peak is lower, leading to this higher ratio, which suggests that there are changes in the secondary structure of the collagen. So we did see an altered bone matrix composition in this cortical bone from individuals with type 2 diabetes. Spectroscopy can also be used to actually look at non-enzymatic cross-linking ratio. Collagen is post-translational modified in order to achieve the elasticity of the bone tissue when it's actually laid down, so that we have enzymatic cross-linking that give the possibility or the properties to collagen that they can decoil and deform due to loading. However, during aging and in diabetes, a higher amount of non-enzymatic cross-linking has been seen due to glycosylation of collagen type 1 because of the high glucose level in the blood serum. Here in the study, we used Fourier transform infrared spectroscopy, and we saw a tendency of higher non-enzymatic cross-linking ratio in the type 2 diabetes with high porosity group. So we wanted to look further how these AGEs are actually accumulating in the bone matrix. Advanced glycation end products are one of the products that are produced with non-enzymatic cross-linking, but they have different properties. So they can be fluorescent or non-fluorescent or cross-linking or non-cross-linking. And there are actually a lot of AGEs that have not been described. The most common described AGEs in bone tissue are pentosidine and carboxymethyllysine. So we did 2 different analyses in this study where we looked at fluorescent AGEs, and while we did not see significant difference, we did see that the values were higher in the type 2 diabetes and the type 2 diabetes group with high porosity. We then performed an ELISA to look at carboxymethyllysine content. We decided to go for CML because it has been shown that in human cortical bone, CML accumulation is actually higher than pentosidine. And indeed, we found a higher accumulation of carboxymethyllysine independent of microstructure, so meaning in both the type 2 diabetes group and the type 2 diabetes group with high porosity. But how does that look in trabecular bone? Sihota et al. Has studied trabecular bone from the femoral head, and they also found a higher ratio of non-enzymatic cross-linking, while there was a lower ratio of enzymatic cross-linking. In another study using also Fourier transform infrared spectroscopy, they showed that pentosidine was higher, and the sugar matrix ratio was also higher in type 2 diabetes compared to control in trabecular bone, while they did not see a difference in total FAGEs. How can we relate, or are these results that we now see in the bone tissue actually related to our serum, to what we can measure in serum? AGEs, pentosidine, and also carboxymethyllysine can all be assessed in serum as well. This was something that Karim et al. Looked at. They did find a difference in cortical bone AGEs in type 2 diabetes compared to controls, but only in the cortical bone and not in the trabecular bone. And they saw a weak but significant correlation with serum pentosidine. In another most recent study, they studied 3 different groups, individuals with type 2 diabetes, with impaired glucose tolerance, and with normal glucose tolerance. And again, they assessed pentosidine, but also AGE crosslinks, and found a significant but not too strong correlation with glycated hemoglobin, suggesting a correlation or an association between AGEs and blood glucose levels. So do AGEs, serum AGE levels, serve to predict fracture in type 2 diabetes? This is something that Gao et al. Looked at. So they were using the FRAX tool, and they were adjusting for rheumatoid arthritis, which is a possibility to do as type 2 diabetes is not included, to be added to the FRAX model. And they found a positive correlation between AGEs and major osteoporotic fractures and hip osteoporotic fractures. In another study, they were focusing on carboxymethyllysine levels in the serum and vertebral incident fracture risk, and they found that higher CML levels were associated with increased fracture risk of vertebral fractures in diabetes, but not in non-diabetic individuals. Putting this all together, there is a study that was looking at 171 type 2 diabetes individuals and 108 individuals without type 2 diabetes. They found a similar bone material strength index, but an increased skin AGE level in the type 2 diabetes group, while BMD was higher in the type 2 diabetes individuals, and they presented with a preserved microstructure. What the authors also did was they were performing transcutaneous oximetry, which is a tool to measure microvascular blood flow in the foot. Using this, they discriminated the type 2 diabetes group into a group with a microvascular disease based on this transcutaneous oximetry measurement, and a group with no microvascular disease. And when they actually looked at this microvascular disease group, they found a higher cortical porosity in the tibia compared to the control group. So this group set out this working hypothesis where they say that increased AGEs and lower bone material strength index contribute to the increased fracture risk, while microvascular disease contribute to increased cortical porosity, again inducing an increased fracture risk, which is further increased due to neuropathy and other factors, while the normal BNP and the preserved trabecular bone volume fraction is actually counteracting towards the increased fracture risk. Summing these clinical but also tissue level data up, it shows that there's an increased AGE accumulation. In some individuals, there's also increased cortical porosity, but also vascular diseases that play a pivotal role in diabetic bone fragility. But how can we actually measure now the bone strength in these individuals? This is where we need to go into the laboratory and have a deeper look into how the tissue responds to different mechanical forces. In the tibia sample study, we have done this to correlate our findings in a clinical setting with our laboratory-based setting. So we have performed cyclic indentation in the transversal direction on the bone tissue. It's similar to impact indentation, only that you don't have one indent, but you do a cyclic indentation. So you can actually also measure how deep the probe penetrates when you are inducing several loads of force. And what we could see was that in this high cortical porosity group, the indentation distance increase was larger. So the probe penetrated deeper into the bone tissue compared to the type 2 diabetes and the control group, suggesting that the bone tissue does not withstand the force as strongly as in the other two groups. Regarding the advanced glycation end product accumulation, we were really curious to know how does this actually affect our collagen properties. And for this, we had the opportunity to go to a large synchrotron facility, the Advanced Light Source in Berkeley, and perform tensile testing while simultaneously shooting X-rays on the bone tissue. Through the tensile testing and marks on the bone tissue, as you can see in this image, we could assess the tissue strain, while the small angle X-ray scattering detection allowed us to determine the collagen fibril strain. And what we could see was that the fibril over tissue strain was actually reduced in bone from type 2 diabetes individuals in the elastic and also in the inelastic region. And this shows that the collagen fibril deformation was lower in bone from individuals with type 2 diabetes. If we want to know how the bone responds to fractures and in a larger scale, so this is really nanoscale. So if you want to move more towards the microscale, we can do 3-point bending testing. And this we performed in a cohort of male individuals where we selected only 2 groups of similar cortical porosity. And we prepared these little beams where we also induced a notch so that we have a starting point for the crack propagation. And while performing 3-point bending, we imaged the crack propagation with a microscope. Following these analyses, we also looked at the tissue level properties. So for example, we performed micro-CT to validate the microstructure of the bone tissue. When we evaluated our crack propagation with high-resolution imaging, we could really see that the crack propagated quite differently in each individual sample. So it was difficult to generalize a crack path. Evaluating our load displacement curves, we could see that the total J integral, which takes into account the elastic and the inelastic deformation, actually did not show any differences between the 2 groups. We also looked at bone matrix compositional properties of the 2 groups, and they were similar. So we concluded that fracture resistance is not impaired in males with type 2 diabetes with indiscernible bone material properties compared to the control case. And this really speaks towards the notion of having specific groups that are at increased fracture risk, while other individuals with type 2 diabetes might simply not be affected. Talking about bone tissue, we know that it's the cells that are actually maintaining bone mass and bone quality. So how does that look in type 2 diabetes? There are quite a few studies that are looking at bone turnover markers in diabetes, and overall, they present that bone turnover markers are lower in individuals with type 2 diabetes. There are not so much histomorphometrical studies out there in this regard. We looked at the bone cells in the mid-diaphysis of the femur, in cortical bone, and we did not see a lot of cellular activity due to the aged individuals and the region of cortical bone compartment, but we did see more osteoclasts in the high porosity group. There is a study by Starb-Lin et al. Where they were actually trying to discriminate whether low bone turnover markers are something that is associated with type 2 diabetes or with obesity. So they compared the type 2 diabetes individuals with a group of individuals who display the metabolic syndrome, and they could actually see that bone turnover markers were lower in individuals with type 2 diabetes, but compared to the metabolic syndrome. So they concluded that type 2 diabetes per se, but not obesity, actually leads to lower bone turnover markers. The question here is, how are these bone turnover markers affected by all the variability that type 2 diabetes brings along? So the same first author also looked at this, and they assessed the dawn effect and the MAGE. The dawn effect is a measurement 1 hour before the breakfast of blood glucose levels until 1 hour later, and it's supposed to, or it's assumed to play a role in the regulation of blood glucose, while the MAGE, the mean amplitude of glycemic excursion, is actually measured over 2 to 3 days, and it shows the variability of the glucose. So it's sensitive to large excursions in blood glucose. What the authors found was, in the first place, that glucose levels were actually higher in the group with a high dawn effect and a high MAGE, but also that this was accompanied by lower P1NP and CTX. And this suggests that glucose control and variability actually influence the bone turnover marker levels. So what about insulin sensitivity? In a study using a Danish diabetes cohort, Nasser et al. Created 3 different groups depending on the beta cell function and insulin sensitivity. So there is a classical group with low beta cell function and insulin sensitivity, a low insulin sensitivity group, and a high insulin sensitivity group. And they looked at bone turnover markers in these groups, and they could actually see that the high insulin sensitivity group displayed with higher P1NP and CTX values compared to the low insulin sensitivity in the classical group. In another study, insulin resistance was also studied and associated with femoral neck strength. And here femoral neck strength was measured based on the DEXA results of the hip, where the femoral neck strength was calculated based on, and they could see that a greater insulin resistance is actually related to lower femoral neck strength. With all this data, the question remains, how can we actually identify individuals with type 2 diabetes and increased fracture risk? One topic, or in this regard, one idea has been studied as the idea of using microRNAs. MicroRNAs are small non-coding RNAs that target different RNAs, most likely through silencing these RNAs in different tissues. And in this study, they have studied circulating microRNAs in individuals with type 2 diabetes and postmenopausal women with fragility fractures, and compared this to individuals with fragility fractures without type 2 diabetes. And they did see that 3 microRNAs were upregulated in the type 2 diabetes group, while 3 microRNAs were downregulated in the type 2 diabetes group, that were also up and downregulated in the fracture group. And these authors suggest that microRNA 550A and 382 could be potential biomarkers to identify the type 2 diabetes individuals with increased fracture risk. In another study, they looked at the microRNA 205, as this has been studied to be related to bone and osteoporosis. And here they looked at patients with type 2 diabetes and osteoporosis. And they could find that this microRNA was highly expressed in serum, but also in the bone tissue, relating directly expression of the bone to expression of the serum in this microRNA. So there are indeed specific circulating microRNA signatures that are different in diabetic bone fragility, but it remains to be explored what signatures have the potential to identify individuals with type 2 diabetes and increased fracture risk. and to have these validated in larger cohorts. To sum this up a little bit, I think it's quite clear that type 2 diabetes is a risk factor for fragility fractures, but it's not an easy target to say everyone with type 2 diabetes has an increased fracture risk. So we need more sensitivity of what is actually going on. And one approach with regards to other comorbidities has recently been done by Alquist et al., where they try to define different clusters of diabetes from a clinical perspective and determine how these different clusters are actually predictive for example, comorbidities such as chronic kidney disease or coronary events. And they found that this third cluster, which is characterized by insulin resistance and high BMI, has a high incidence or postulates a high incidence also with chronic kidney disease and coronary events. So it would be possible, or it is maybe a suggestion to look whether these individual clusters or whether there is a specific cluster that is actually related to fragility in type 2 diabetes. So to sum this up a little bit, the diagnosis of individuals with type 2 diabetes and fragility fractures can still be improved. And it is important to consider different risk factors and whether they are population-based or individual risk factors that come into play. We still lack a direct access to bone tissue or to the bone tissue level, of course, except for when we take biopsies, so that we get a better readout of the actual bone quality. And another very interesting fact is that I have not covered here at all is what are the treatment options, but also how different diabetes treatments actually affecting bone tissue. This is especially interesting right now with the new developments of GLP-1 inhibitors used as a treatment in type 2 diabetes, where we actually don't really know how it will affect the bone tissue itself. Overall, all these data show how complex and heterogeneous type 2 diabetes is, and that it requires really a joint force to decipher more what are the underlying causes of type 2 diabetes bone fragility, even though we have also already discovered a lot. To sum that up, if we look from molecules to strength, we know that an impaired bone quality contributes to the reduced strength in the diabetic bone fragility. And we do know that it requires, or I suggest that it requires combined material and cellular analyses to advance our understanding of the underlying mechanism and to go deeper into what is actually happening in bone that is subjected to diabetes and high glucose. It is also important to include the clinical profile of patients with type 2 diabetes, as this plays a pivotal role. And I think it's really great the attempts that have already been done to combine interdisciplinary research and different research directions to decipher the underlying mechanisms of diabetic bone disease, which is really needed. And by this, I would like to thank everyone who has been part of my scientific journey, and especially my current lab, the Molecular Endocrinology Department, and you for listening.